Today we will explain our pathology model on peptic ulcer disease and its real-life correlation. This model represents the stomach and duodenum, highlighting ulcer formation, acid secretion, and complications. Peptic ulcers occur when the protective mucosal lining is damaged, allowing acid to create deep sores. The major causes are H. pylori infection and NSAID use. Here you can see benign duodenal ulcers, commonly located on the posterior duodenal wall. Malignant gastric ulcers, which have heaped up margins. Esophageal ulcers, which may progress to Barrett's esophagus. Here we have an actual specimen of peptic ulcer disease, demonstrating similar features as seen in our model. Notice the ulcerated mucosal areas, inflammation, and possible perforation sites. Just like our model, in real specimen, we observe gastric ulcer with irregular margin and fibrosis, duodenal ulcers that penetrate deeply and may perforate, complications like bleeding, perforations, and obstruction. Peptic ulcers are not tumors, but mucosal defects that extend beyond the muscularis mucosa due to acid peptic digestion. They are classified into gastric ulcers in the stomach and duodenal ulcers in the duodenum. Peptic ulcers are very common worldwide, affecting 5 to 10% of the people at some point in life. The leading cause is Helicobacter pylori infection, which affects nearly 50% of the global population. Symptoms vary depending on the ulcer type. Gastric ulcers cause pain that worsens with food, leading to early satiety and weight loss. Duodenal ulcers cause pain that improves with food but worsens later, often presenting with night pain. Complications like bleeding, perforations, or obstructions can occur if left untreated. The gold standard for diagnosis is endoscopy, which allows direct visualization and biopsy. Helicobacter pylori testing is done via the urea breath test, stool antigen test, or biopsy-based rapid urease test. Microscopically, benign ulcers shows necrotic debris, inflammatory exudate, granulational tissue, and fibrosis. If Helicobacter pylori is present, we see curved bacilli with neutrophilic infiltration. Malignant ulcers show atypical glandular cells, pleomorphism, and high mitotic activity. With proper treatment, 90% of the ulcers heal completely using Helicobacter pylori eradication therapy and proton pump inhibitors. Surgery is only needed in complications like perforation. Malignant ulcers have a poorer prognosis depending on the stage at diagnosis.